I'll formally stand here for a few minutes until we have a chair, but I wanted to just welcome, this is probably the most exciting, well, no, everybody's was exciting. No, but truly, these are incredible, incredible women representing amazing organizations and doing even more incredible things. So I'm very excited to have this conversation with the three of you. And I know I probably bug Hope and Melanie on a daily basis. We work very closely. I've had the pleasure of working closely with Harris Health and the Houston Food Bank for many, many years. And Roxanna and I have intersected on Zoom calls. But it's wonderful to have this conversation because a lot of the work that we do at the School of Public Health, as well as UTHealth Houston and the Center for Health Equity, resides in these partnerships. And without these partnerships, none of the work that we would do, we one, wouldn't be able to do the work, but two, it wouldn't be impactful because it's real world, right? So they're the ones who make it happen from a real world perspective. Oh, thank you. Okay. All right. So let's first start with introductions. Do y'all have those are, I think, your mics. So I would love for the group here to hear from each of you a little bit about yourselves and your work. And I think we have slides here. So let's first start, Melanie, with you at the Houston Food Bank.
Okay.
Yep.
So my name is Melanie McGuire. I am the Senior Director of Programs at the Houston Food Bank. I have been in the Food Bank Network, which our national office is through Feeding America, for 13 years, and had the pleasure and opportunity to, as Shreela mentioned, work very closely as it relates to this work. At the Houston Food Bank, we really see our work in health in kind of what we call a food for change strategy, which is we were really looking at the root causes of food insecurity. And we have identified three key areas that we are placing major investment in. Those include education, health, and economic mobility. And so what you see a little bit is here is kind of the framework that we operate at Houston Food Bank as it relates to health. We heard a lot today about food insecurity. And really, I just would say that through this exploration and many of the intervention models, we are working in partnership with Harris Health and many of the healthcare systems across 18 counties. We recognize that food insecurity is complex, right? And so our intervention methods really speak to the diversity of communities, honoring culture and understanding that. And then really just that different models are going to address different populations at different points in time. So that's really what our health pillars really speak to is foundationally we're addressing food insecurity, but as you heard today, the importance of referrals, the impact of utilization, and then those that are most chronically impacted by food insecurity may need different intervention methods.
Thanks, Melanie. Next, I'd love for Roxanna, if you don't mind giving an introduction of yourself and your work.
Thanks. I'm Roxanna Cruz. I'm a physician in internal medicine. That's my background and training, also in public health. And I work with the Texas Association of Community Health Centers, which is a membership organization for all of the now 77 federally qualified health centers, or what we call also lookalikes, here across the state of Texas. So those 77 health centers are over 650 sites in all of, 127 of our 254 counties. Those are all the numbers. And what health centers do differently than most organizations or health systems is we have 4 criteria. One is that we're always in a health professions shortage area or medically underserved area. We provide medical, dental, and behavioral health services, all of those, plus some other support services, and but at least those 3. And then we're community-based and community-driven in the sense that 51% of the board members from each of the health centers has to be from the community and actually be a patient in the community. So it's very much consumer-driven in that way. And then the 4th is that we see all comers. So this is also very unique to us. That means that everybody who walks in the door gets a financial screening. If they have access to Medicare, Medicaid, that's great. We make sure that they're signed up. And if not, then we will put them on a sliding fee scale in order for them to be able to be seen. So those are the 4 criteria for federally qualified health centers. And we are a membership organization, so we have all of these under our umbrella. And we provide training, technical assistance, and advocacy, amongst other things. So in a nutshell, thanks.
Thank you, Roxanna. And I don't know if you have a slide.
Oh, yeah.
Oh, this was your 4 pillars.
Yeah.
Okay.
4 requirements.
Thank you.
Yeah, you don't. Those are all the numbers I gave you.
Well, but this is wonderful information. Okay, well, last but not least, we have Hope Galvan from Harris Health. Hope, Dr. Galvan, Dr. Cruz. But if you don't mind, we can be on first name basis on the panel.
Of course.
So if you don't mind, Hope, giving an introduction of yourself. and
Okay.
your role.
So good afternoon, everyone. Esperanza Galvan. Everybody knows me by Hope. By background, I am a doctoral prepared nurse. I've been a nurse for a very long time, like 25 years, maybe longer now. I was 5. I always say that when I graduated, in case you're adding the numbers up. But I've had the privilege of, through my career, I started in South Texas, very rural, in a small hospital. And then I moved to Houston, which was quite a shocking change. But it's really been a journey as far as my career and being able to get into population health, because I've been able to get a taste of rural medicine, clinics, being in a primary care infectious disease clinic, dealing with patients who came in with HIV and other things like that. And mind you, this was many years ago, right? Things were different. And then advancing into the medical center. And in the medical center, again, being able to have the most advanced technology in medical care, but still seeing the same problems that I saw in rural and in small clinics, even here in Houston and in the community of Houston. So all of that to say that I'm now working at Harris Health, who, if you know anything about Harris Health, 50% of our patient population is uninsured or we're underinsured, right? And in order for you to qualify for financial assistance at Harris Health, a family of 4 can make no more than $49,500, maybe $50,000 a year. So imagine living in Houston on that salary, trying to care for your family of 4. So our job at Harris Health, as part of population health, is to really create interventions that target the upstream, right? So I have the operational and strategy oversight that includes community health workers who are out engaging our patients in the communities who have uncontrolled diabetes or are disengaged with the system. I also have leaders, with Denise LaRue, who's my partner here today, oversight of patient-centered medical home, which is our model of care for the clinics. Very team-based, very patient-centered. We also provide, of course, our bigger strategy, which is food as medicine, across our system. I think we are now at our 6th location for on-site food pharmacies. And I always say for us, it's not about food distribution. It's really about providing our patients a hand up and also empowering our patients with this particular intervention. And then one of my other programs is our Access to Care, so to speak, program, which is connected with our Healthy Connect, which is our remote patient monitoring program. That particular program is helping our patients who are coming in with uncontrolled blood pressure get a blood pressure machine, be able to educate them. They check their blood pressures at home, and we're able to see pretty real time if their blood pressure is out of control or if they didn't check their blood pressure today. This is all just augmenting primary care, right? Some of our patients need a little bit more than others. And I think last but not least, our Cancer Resource Center, which is small but mighty.
Thank you. And, I think for this particular panel, one of the things as we were thinking about who do we want on this panel, the reason you guys came to mind was because of the incredible partnerships that you have built to really expand the footprint and impact for the communities and the patients that y'all are serving. So Hope, since you have the mic already, let's start with you on what are the benefits of partnership in terms of addressing population health outcomes, these very sticky issues that you're trying to grapple with, right, for your patient population? Why should health systems think, and how should they be thinking about these partnerships as they're developing their strategic priorities?
Yeah. So the benefits are endless, right? And sometimes they're positive and sometimes they're negative, but you learn regardless. I'll tell you from somebody who started Food RX at Harris Health, being a nurse, I'm very clinical, right? And being able to put myself out in the community to go and talk to the Houston Food Bank. I mean, I wasn't sure what to go say to them, but what I knew was that my patients were being screened for food insecurity, and I knew that they were expressing a problem, and I knew that my team was tired of also saying, you should, you need, you must, and knowing that our patients couldn't, right? And seeing them come back, whether through a readmission or another visit, feeling distressed, right? Because it's like, I want to eat better, but I can't. So long story short, I'll tell you, working with the Houston Food Bank, I think it was bi-directional. This was before Melanie's time, because they were like, Hope, we've tried to work with you guys before, but didn't work out. And so then I was like, well, what happened, right? And so they explained, right, what their struggles were. But then, being able to work with them, we both discovered that they were trying to change their model of food distribution in the sense that they wanted to see what was the health impact for the community of what they were doing. They were very good at food distribution, but they wanted to say, what actually are we doing? From my perspective, again, I just told you what we were trying to address. It was really, working with them. It was, help me help you and help each other, right? And help our patients. We were able to listen to each other, and I was able to commit to say, look, you come work with us. I have clinical data. I can't give you patient level data, but I can tell you what's going to happen if we put this program in place, right? So several years, many long nights of contracts. Poor Denise, my partner in crime again, working with the Houston Food Bank, learning what is food distribution, how do you handle food. We learned so much. From that relationship, it was them being able to connect us to a resource that we needed for our patient and more. Because ever since then, gosh, it's been now 5 years celebration, 6, 7 years, because it took us 2 years to actually get the work done. So 7 years later, we're still reaching out to each other, and we're still connecting with each other for grant opportunities, for support, being able to connect with other organizations across the country with our model. So that was a CBO, right? From the academic side, I mean, I'm not saying this because Dr. Sharma is here, but it's really been the support that we don't have internally as it relates to evaluation. Being able to work with her has helped me sustain the program because I'm healthcare, right? I still have to show a return on investment. I still have to show that this is not another feel good, right? So working with her and her team is really helping me do that, right? We've got off on an exciting call this morning, and through the whole time that we've dealt or worked with this dissertation for this student, it's exciting. Yeah, it's been phenomenal. I couldn't have done that without them, right? We don't have the resources at Harris Health to be able to put evaluation behind our programming, but more importantly, that to be able to do that, to sustain it. Because we all have executives coming in and saying, why are we trying to solve society's problems? What are you doing? But if we can show them that because we've done this, we've improved an A1C, that means a lot, right? That means a lot to folks. And let's be real, like that, it's a business at the end of the day. And I think that the other thing with working with both of them has been the networking. I don't have enough hours of the day to be able to go and talk about the program or connect with someone who's already doing it in San Antonio that maybe wants to learn more or that I should learn more from, right? And my partners at Harris Health don't have that time either. So it's really that networking, that the evaluation piece, the partnership piece, that it's so much opportunity. But I also will say at the very beginning, it was very difficult, trying to get a legal agreement in place. They were different at their organization. We didn't have the services that we had, but we kept going, and it was the tenacity that kept us together, and we pushed through. So that's why I said, it's positive, but there's also things that you have to work on. So,
thank you so much. And Roxanna, you have to think a little bit differently in terms of partnerships, right? Where you're coming from. Could you share a little bit from your lens and where you're sitting at on how you're seeing partnerships, and what is your strategy as you think about partnerships to improve population health?
Okay, thanks. So I think from our perspective at the association level, it's thinking about what our health centers need, first of all, and our health centers, again, they're embedded in the communities, and having a clear understanding of that in Texas, it's a large state. We have urban, rural, we have frontier, and truly it does go to relationships. It does go to what is it that we can, is it needed? And then what is it that we can do? And then who do we need to bring into the conversation? And then make a plan to make that happen, which takes time and relationships and legal documents as well. So for sure, those are always in there. So it's I think the importance of looking at it in that way is that it's a systems approach. And if we can actually create a system where we're connected to each other and helping each other out, I think we'll get further faster for sure. I think the idea behind population health is that we look at large demographics or small in smaller communities or in rural, urban setting, rural or frontier settings rather, and think about what's happening in this community and and a lot of the information comes in through screenings like non-medical drivers of health, of course, as well as the demographics, as well as the age brackets, and even what the trends are in those communities, and then specifically the health outcomes and tracking that as well. So when we, as an individual, so my background is as a physician. I trained in New York. I'm from Texas. And I remember sitting as an intern, sitting in a journal club and reading about maternal morbidity and mortality. This was a long time ago. This was decades ago, I'm going to say. And I remember thinking, wow, how is this happening? Particularly with women of color, and feeling moral distress, frankly. And so then I moved back to Texas and began working in community health centers, and saw in an urban setting in Dallas. And I saw, oh, this is the reality. It is actually happening, and perhaps I can make a difference. But at that time, I was young, and I thought, you're trained to be one-on-one with your physician, with your patients, and so you see them that way. But truly, we had to take a step back. And in community health centers, we're obligated to look at numbers and trends and report them, and try to figure out why it is that we're still not moving the needle. So, but those questions about the why is not, it's critical, I think, to everybody in the room, but not always is it critical to actually confront the realities that many times it's the systems that have embedded within them how we got to that state, and then you have to really take it apart and maybe put it back together, which is not all that popular sometimes. So saying all that, and then flash forward, 20 years, and now I'm at the association level, and I'm seeing we are still facing the same problems. How is that even possible when there's so many smart people in the room? So what we can do is look at it a lot differently in terms of a systems approach, but all of us have a role in that system. Mm-hmm. And in public health in particular, linking it to the practice of medicine at the community level, at the private level even. I mean, you can really translate that at any level and should be at all levels. So again, no one person, no one individual can do this. It's not a private practice that can change things. What can change things are groups of people who are thinking about the same problem and trying to figure it out from different angles. So it's not just the clinicians, it's actually the School of Public Health. We've had a great alliance with the School of Public Health. Dr. Fernandez was, I think, the first person that was introduced to me that first year, 7 years ago when I was working over at TAC. And from there, a lot of our continued conversations, discussions, grants, trying to, work together, and as well as some of the programs that we've developed from the get-go up until now, including the trauma-informed care program. So just to say that if you think of how you can bring in partners, develop those relationships, which take time, create trust, and look at those problems as a system approach, I think that that's the biggest benefit, and we can make that difference, is my hope anyway.
And invest in relationships.
Yeah.
I think that's a big one. Melanie, I want you to, you're amidst health system researchers, that's what most of us do, one or the other. Can you share from a community organization perspective? I mean, and I feel like the food bank is also an incubator of other community organizations. Like you've incubated Brighter Bites, you've incubated so many other programs. What role do community organizations play in fostering these partnerships and relationships? How do you think about these things? And then I think the part that I want you to share with everyone is, what would you like us to know as we approach the food bank in building these partnerships? What is it that we should know and come to the table with, right? How should we be prepared in building a partnership with the Houston Food Bank, especially keeping that particular fact in mind that you are also, you're a CBO of CBOs. Yes. You're a CEO of CBOs in some ways, right? Like you're incubating and fostering relationships. You have that no wrong door policy with the food bank. So if someone comes for transportation and food, you'll give them food, but you'll also connect them to transportation services. You'll also enroll them in SNAP. So in the model that you have is so robust. I'd like you to educate us as an audience on how you want us to engage with you as a partner. How should we prepare ourselves?
Well, thank you, first of all, for that very thoughtful question. It's great when we get asked that question. I think I'll answer it twofold. One is I stand here before you, or sit here before you, as a organization that does a food bank. So if you don't know that there is a food bank in every zip code in every part of the country, I would encourage you to connect with that organization. We are a network at its core. And beyond that, we are a backbone for numerous community-based organizations. And so the Houston Food Bank alone supports over 1,600 entities of community-based organizations that can range from faith-based organizations to schools to supporting health system work. And so really that, we really think about that in two ways. One is as a leading organization, in what ways can we provide the infrastructure and frameworks for community-based organizations to engage with health-based systems? And that goes from rural communities to urban communities. And so we're always intentional thinking about scalability and sustainability. I want to acknowledge a question that was asked earlier to your second point, Shreela, around, well, how do you connect people? How do you know people actually get the services? That is the number one piece of information that we hear all the time, right? Is we can be the most effective at screening for services, but if we don't actually know people are able to connect to those services, then are we actually moving the needle? In May, you will, if you are not connected to Feeding America, our national organization, we release what we call Map the Meal Gap, which is rates for food insecurity by county, by food bank, by zip code, around children, around seniors. That information is going to be released.
And so I'd really encourage you to look at that. But that is the highest level of standard that we look at. That is what keeps me up at night. Is not only we can build great systems to connect people to resource guides and services, but how do we actually know people are being served? And that's really where it's important, I would say, to the second part of your question, to really engage community-based organizations in the process, right? The number one barrier for community-based organizations is not actually technology, it's not equipment, it's labor. Most community-based organizations have a very small amount of staffing and rely heavily on volunteers. And so some of the major investments that the Houston Food Bank is putting together, as other food banks across the country are, is in what ways can we support technology toward automation of repetitive services for community-based organizations so that they can really focus on the work they're ultimately interested in doing, which is providing the neighbor experience work that we all think is so intentional and what's ultimately going to move the needle on being able to address some of these areas. I would say finally is just the last point to remember as researchers or others is that organizations don't sit in isolation. The pantry down the street that's providing food assistance is likely providing other services. And so it's important to ask. Co-enrollment of services is the most effective way, as Shreela and I know with some of the studies we've done, is it's not simply sufficient to just provide food, but when we can provide food in culinary medicine or when we can provide food and access to federal benefit assistance, we are moving the needle further in this work. And so the other part is just be intentional as you think about your relationships and make sure you ask, because oftentimes there's assumptions about what organizations do and do not do. And the reality is many of these organizations are placing a lot of time and investment into a lot of different services that can be leveraged further.
Thank you. And Melanie, since you have the mic, let me ask you, can you share, I mean, this is just between us, right?
Sure.
Can you share perhaps how are you thinking, like when a partnership is not working,
Yeah.
right? How do you think about, these are sensitive relationships, right? Can you share with us what should we know about that particular piece of how do you know when a partnership is not working, or what are the ingredients of a good and bad partnership? What might be some of the metrics of success, right, that you use as you're thinking about partnerships like this? These are the ones I want to build on, right? And these are the ones that, I'm glad we tried, but.
Right. Yeah, I think that's so critical now more than ever. I would say that, first of all, we generally approach this work with curiosity, right? And so we recognize that we are not going to move the needle on food distributions by distributing food. We are the largest food bank in the country. We've distributed more food than any food bank in the entire US, and yet we have not moved the needle on food insecurity. So we need a different approach. So we are open and curious as we engage in partnerships. But I'd say, and the great example would be with Harris Health, is we're really intentional and transparent about how things are working and really understand why. One of the big learnings around this work has been understanding workflows, right? Every health system, every program has a different workflow, and we respect that. And we understand scalability, particularly around our network of organizations that are already addressing the emergent needs of people today. And so one of the things about thinking about things like referral tools is there's the connection aspect of it. There's the utilization. How often does someone need to access services? But then what is the capacity of that organization? And is anybody asked? And so those kind of things are really important to thinking about thriving relationships. And we've definitely had a lot of pivots in our own Food RX work where we've been like, oh, well, man, we're doing such great work on A1C, but we haven't seen really anything on high blood pressure. Why is that, right? And it's really approaching it with that openness and transparency and being willing to pivot. I mean, I think we have really shown that through the pandemic, that we've come up with some great innovations through that space. And so that just that willingness to say, hey, we're not going to continue to invest in something that doesn't seem to be moving the needle. how can we think about this differently? And I would just say, finally, recognizing that every community is different and it's not a one-size-fits-all model. As you saw in that pyramid, some communities need high-touch, high-intervention work. We can, as much as we love home delivery, we cannot scale home delivery in 18 counties, not today at least, without a funding mechanism. So really thinking about being intentional from the beginning is a great learning that we had to ensure that we are not overcommitting to something we may not be able to scale.
Yeah, I smiled when you said this is between us, right? Because this is before Melanie, right? When we first started with the Houston Food Bank, we were getting to know each other, and mind you, a legal agreement helped us a lot, right? To become very nice to each other. But in actual practice, I remember the first time I started getting food from them, and I walk into the food pharmacy, and I'm like, "What is this? Onions? Like, what are we doing?" Right? Well, you weren't there, but it was Esther, Harry, and Reggie. You remember these folks. I still communicate with them, and we're still, check in periodically. But it was, it kept happening. I was like, this is not going to work. Like, we are trying to give, folks healthy produce, and we're trying to, be the picture of health and show folks that when you come into these food pharmacies, as a healthcare provider, this is important. This is part of your care plan. And so seeing a whole bunch of watermelons is not going to work. So it wasn't working initially. And then finally what happened was Esther, who was, our partner there, she's like, okay, I'm going down to the warehouse, Hope, because I get it. I'm like, if we don't change this, our A1Cs are not going to improve. Like, I won't be able to show you anything. And she's like, I'm walking over there. And so long story short, she did that on her end. But then she's like, okay, Hope, I've already gone to go talk with them. We're doing the best we can. On our end, it was like, okay, I get it, right? I get that there's limitations. COVID hit us. That was even worse, right? It was like, okay, I totally get it. And then that's when we agreed that we were going to go ahead and use some of the money and donations that we were getting to be able to supplement. We knew we were going to do it from the beginning, but I was unreasonable, I think, as a nurse and someone who had not done this before, to expect them to, I just want healthy stuff. Like, what can you send me? And mind you, I visited a lot of a lot of pantries. I was still clueless, but we had such a great relationship. And again, we're still friends. The folks that I worked with back then, who are in Atlanta and everywhere else, that we could trust each other enough to say, I want to help you be successful, but what you're doing, this is not going to work. But then I also stepped back and was able to say, you know what? I do want A1Cs to change, not just to help them, but to help myself. So we had to invest in that. So transparency, being able to really, when you come together and you say, you're going to agree to do this because I want to see a change in health, I want to see this particular outcome, you're going to have to negotiate, right? It can't be only what you want and what you think is right. So, that's the moral of the story for that one. Probably said too much.
No, just between us.
Just between us.
We do not distribute onions.
Sign the
anymore.
con-
Just
sign
to
the-
make sure that is not on record.
Anything you would like to add?
I think it was well said. Just the one point that I would make is, from the get-go, know your partner, know what their goals are, know what your goals are, and then make a plan together to get to what, if it's one goal or two goals, that's fine. Just to be super clear about that, so that everybody gets to what their deliverables.
Mm-hmm.
Yeah, and I just want to, I don't know if everybody knows this, but Harris Health has one of the most integrated models of food prescription program. They actually have co-located these pantries inside their clinics and hospital systems. So it's really very visible. They also have teaching kitchens there, which is fantastic. So it's also a very visible investment, right? In terms of, so I can totally see, although I think onions and watermelons are pretty, but all this to say is that from demonstrating, right, a return on investment per se on these resources that the health system has invested in becomes even more critical, right? When it's co-located within physically in your space. So definitely appreciate the need for having those conversations as well. I'm not going to hog all of the time that we have of the panel, but I do have a final question for you before we open it up. What is the one key takeaway that you would recommend to the audience to advance partnerships for population health? And it's okay if you want to reinforce something that you already have, but what's one key takeaway? Roxanna, maybe we can start with you.
I think it's starting with a needs assessment, I'm going to say, because I think that that's where you can hit the target most, because there are a lot of needs. And so narrowing things down and then prioritizing so that you can make a plan and then reach out to those partners that are may be involved or maybe you want to be involved and just reach out. I think I did a lot of cold calls and it's fine. It works. And I don't think, I didn't get many people hang up on me. But it's a way to sort of be vulnerable and say, hey, I need your help. And I know you're somewhere in my community. Can we talk, just have a conversation and then begin there?
I go last. I mean, I think what you heard today, or certainly this afternoon, was really the power of relationships. And I think approaching that work with curiosity, I think we are tremendously fortunate here in Houston to have such great academic institutions, health systems. It's really bridging those connections across these areas that's really important. And I always say to kind of approach it with curiosity because what you think you know about an organization may not be what you know about an organization. Oftentimes I'm in these meetings and they're like, oh, I thought the Houston Food Bank just helped people that needed emergency food. And I'm like, oh no, it's so much more. So I would also just challenge you or employ you to go visit some of this work to see it in practice. It's oftentimes different when you're reading a paper versus seeing what this is in practice. So whether it's through a health system or it's through a visit to the Houston Food Bank, there are numerous opportunities for engagement. And I think those could be great examples of what to consider as you're thinking about the bridge between what we know from studies to what is implementation.
Last but not least, Hope.
I hesitated and I kept looking at them because y'all go first because it's not easy. I think from my perspective, it's, a partnership is two ways, right? Don't forget that, I did, I'm not going to lie, and I still do, right? But I have to bring myself back, right? That it's like when you partner, you agree to accomplish something together, right? And it's got to work for both of you all. And maybe it doesn't work for both of you all 100%, but there's somewhere in the middle and you commit to that. But the key is, and I've been through a lot of different partnerships, and the best ones are the ones that we're always communicating, right? Good, bad, ugly. I mean, it's gotten better through the years, but I mean, we were texting at night, we were, emailing at night. But we respected each other. We were trying to accomplish something, and the communication just kept flowing and still does, right? Same here, right? It's like, that's what I think that sometimes gets lost, is that we do something together, it gets accomplished, and then we just go on about our business, and we don't circle back to say, it's like, we accomplished this, now what? Or how do we disseminate this? Like, how do we share it with the rest of the healthcare industry or whomever? So I think that for me, it's really that, is making sure that you recognize what a partnership really means, and it's not one-sided, and then be patient.
So patient, persistence, communication, engagement. I mean, fantastic. What a great piece of advice from our panel here. Let's open it up to the audience for questions that you may have to our panelists here. Maria, do you have a question? Oh, okay.
Yes, thank you. This has been phenomenal. And so I have a couple questions, but I'll just start with one, and I'll direct it to you first, Roxanna. So we heard about the amazing trauma-informed care program, and that I'm not exactly sure what year it was, but that came from your deep concern of sort of what you were seeing in the health centers with children, but also with adults, and then because of partnerships sort of flourished. I didn't know anything about that topic. So I handed it over to the very capable Paula Caccaro, and she just has run with it and made it amazing. So I guess my question is, how does that sort of thing happen, right? How does the communication where, as researchers, as people that are wanting to implement population health, but also wanting to ask questions that are generalizable and be researchers, how do we ensure that the directions we go are responsive to the needs, the actual needs that you all have? And I'll let you go first.
Thank you. Yes, so important. So I think that the way it happens is it does start with curiosity for sure, and what, recognizing that there are some changes that need to happen. So the collaboration between the health centers being, again, embedded in the community. We also are very much committed to those communities, not only because we have the 51%, but because the staff is from the community as well. In every single health center, that staff is from the same community. So they're very invested. So the next question is seeking out the health center and really understanding what that scenario looks like. What is happening in the health center? What are the needs? There's all in a community health center. It's a nonprofit, and there's always a lot of competing priorities. So it's maybe visiting the health center and seeing how busy it is and how many languages are spoken, or what the patient demographic looks like, not just on paper, but in live, like while you're there. So I think it's being very attuned to your partners and really meeting them where they are, and and recognizing that there are some limitations. And that is actually super important, because it is in fact resource challenge setting, and just starting with that. So if it's a resource challenge setting and you have a great a prototype for a study, it's probably not going to work perfectly because it's real world. So I think it's coming to terms with, okay, what is the real world that I'm talking about, and whom am I talking to? Who are the patients that I want to reach? Or what does the staff look like? Being very grounded, which is the origin of public health, which is why I love it. So it's just, be real, right? And then recognize that the models that we use in research are sometimes a little bit, they're very academic, right? Which is fine, but then you have to adjust. And so that's the piece.
And I your comments remind me of a quote that I love from Larry Green. And he said that if you want evidence-based practice, we need more practice-based evidence. Because often we are trying to implement evidence that was created in conditions that aren't real world. So yes, what you say really resonates. And I think just nobody has any other questions? Okay, I'll just ask another question, and it's related to this, and maybe, well, any of you. So one of the sort of key strategies in implementing evidence-based interventions is creating collaborations, partnerships, sometimes referred to as practice-based research networks, or I really like the term collaboratories, because it has that collaboration in the word, but it's also this sense of we can learn from practice. So my question is, what do you think about that? Do you think that because that's sort of I think a concept that has come from the implementation science field, but what do you all think about that? And do you think that there's value there?
I think Melanie should go.
Yes. That is the foundation of how food banks started. But also, yeah, we are all part of a collaborative called the Health Equity Collective. Myself and Harris Health co-chair the food equity space, or sorry, food security space. Yeah, and so yes, I mean, much of the work we've been able to do has been through facilitated collaboratives. whether that's funding opportunities or whether that's prioritization or needs assessment work or identifying gaps. And it's really through that work we've been able to identify where there are gaps where we need to bring others in because we are also myopic sometimes in our thinking. So it absolutely, I think that is very central to this work and necessary if we're thinking about scalability.
I'm with the yes. Co-laboratory sounds great because you're experimenting and you're being upfront about it. Like, okay, maybe this will work, maybe it won't, maybe you need to pivot, maybe there's a different idea, different way, different approach, but it's collaborative. Yeah.
I got nothing to add.
Thank you so much. Let's give a hand.